So what's up guys? Today we will talk about the sulfonamides. First of all, we will look at the history of the sulfonamide. Sulfonamides, also known as the sulfur drug. It was the first effective chemotherapeutic agent used to treat the bacterial infection. It was discovered in 1932 by the Gerhard Domark, a German pathologist and the bacteriologist. He identified the antibacterial activity of the prontosil. That is the most important. Prontosil is actually a prodrug. It becomes metabolized in our body and convert into the sulfanilamide. That is actually a sulfonamide. So prontosil is a prodrug. It becomes activated in our body through the metabolism and convert into the sulfanilamide. So on the basis of the antibacterial activity of the prontosil, he got the Nobel Prize in Medicine in 1939. Next, if we look at the classification, so we have categorized the sulfonamides on the basis of chemical, structures, absorptions, and the different combinations therapies. Chemical classification: simple sulfonamides that include sulfonilamides and the sulfadiazine. Substituted sulfonamides: sulfamethoxazole and the sulfasalazine. That is actually the substituted sulfonamides. On the basis of the absorption, oral absorbable sulfonamide, sulfadiazine, and the sulfamethoxazole. These are basically oral absorbable sulfonamides. Oral non-absorbable like sulfasalazine. Topical, you will see the silver sulfadiazine and the sulfacetamide. Combination therapy, we can use the sulfonamides along with the different other antibiotics like trimethopriums and the sulfamethoxazole. Here is a combination TMP-SMX, pyrimethamine and the sulfadiazine. So this is the classifications of the sulfonamides. Next, if we look at the mechanism. So first of all, in the group A, we will see the normal mechanism of the action. First of all, para-amino benzoic acid, also known as the PABA, 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 para-amino benzoic acid. So, para-amino benzoic acid convert into the dihydrofolic acid, or you can say dihydrofolate, with the help of the enzyme dihydroteroate synthase. Next, dihydrofolic acid convert into the tetrahydrofolic acid with the help of the enzyme that is dihydrofolate reductase. So this is ultimately tetrahydrofolic acid convert into the DNA. So these are the two most important enzymes helpful in the synthesis of the tetrahydrofolic acid, which is further used in the synthesis of the DNA. But when we use these sulfonamides or trimethoprim, sulfonamides act on the dihydroteroate synthase and block its activity. Means it blocks the conversion of the para-amino benzoic acid into the dihydrofolic acid. Similarly, trimethoprim act on the dihydrofolate reductase and ultimately, it blocks the convergence of the dihydrofolic acid into the tetrahydrofolic acid. When there is no tetrahydrofolic acid, then there will be the no synthesis of the DNA, and ultimately there will be the no growth of the bacteria. So that's why sulfonamides is bacteriostatic drug. Next, if we look at the bacterial spectrum, antibacterial spectrum, so it is good for the gram-positive bacteria like the Streptococcus pyogenes and the Streptococcus pneumoniae. It can also be good for the gram-negative like Escherichia coli and Haemophilus influenza. Others, Chlamydia, Trachomatis, and Toxoplasma gondii in combinations with the pyrimethamine. Next, we will look at the resistance, how bacteria develop resistance against the sulfonamides. First one is the overproductions of the PABA. So in that case, you will see there is a competitions between the PABA, para-amino benzoic acid, and the sulfonamide. With the binding of the, here is the sulfonamides, with the binding of the dihydroterroate synthase enzyme. So, so due to the overproductions of the PABA, most probably PABA will bind to the enzyme and the normal process will happen in that case. So this is how bacteria develop resistance against the sulfonamides by increasing the concentrations of the PABA. So due to the increase in the concentration, ultimately there is more chances of binding of the PABA with the enzyme, that is dihydroterroate synthase. Next is the mutation in the dihydroterroate synthase enzyme. When there is a mutation in this enzyme, so in that case, sulfonamides won't bind to this enzyme. Increase efflux and decrease permeability. So this is the most important thing. Here is the bacteria. So bacteria basically reduce the permeability. Drugs will not enter, drug will not enter into the bacteria. That is the one thing. And ultimately increase the efflux actions of the sulfonamides. When there is no sulfonamide inside the bacteria, then there will be the no action of the sulfonamide in that case. Next is the altered metabolic pathway. Bacteria can also choose the other pathway to synthesize the folate as well. So that is the important thing. Bacteria can synthesize the uh, tetrahydrofolic acid by itself, while in humans require the folic acid from outside the body, means in the form of the diet. Next is the pharmacokinetic absorption. Oral sulfonamides very well absorbed through the GIT tract, and the peak concentration occurring within 4 to 6 hours. Distributions, uh, sulfonamides can cross the blood-brain barriers and the placenta, and sulfonamides has ability to bind to the proteins like the albumins. Metabolism metabolized in the liver, and in that case, sulfonamides go toward the acetylation process. Next is the excretion, excrete through the kidney. So kidney function should be proper in the patient who are taking these sulfonamide. Next, contraindications, hypersensitivity or allergic reaction to the sulfur drugs, pregnancy, increase the risk of kernicterus, means increase in the bilirubin levels in the neonate. Now, that is the important thing. Here is the albumin. Albumin, and here is the sulfur drugs, and here is the bilirubin. So bilirubin and the sulfur drug has ability to bind to the albumin, but the sulfur drug has a large ability to bind to the albumin. So that's why bilirubin will remain free, and bilirubin will start accumulating in the brain of the baby and starts damaging the brain of the baby. In that case, that is the kernicterus. So risk of the kernicterus increases in neonates who are taking the sulfonamides during the pregnancy. So as we have already seen that the sulfonamides can cross the placenta and enter into the body of the neonates. Next is the G6PD deficiency. Again, that is the most important thing. G6PD glucose 6-phosphate dehydrogenase deficiency increase the risk of hemolytic anemia in that case. Severe liver and the kidney disease can also exaggerate by taking the sulfonamide. Next, adverse effect, hypersensitivity reaction like rash, fever, Steve Johnson syndrome, and the toxic epidermal necrolysis, you will say peeling of the skin. Hematologic effects like agranulocytosis, increase in the level of the agranulocytes, aplastic anemia, hemolytic anemia, especially in G6PD deficiency individuals. Renal effects, crystalluria formations of the crystals that actually can damage the kidney, that is nephrotoxicity, GIT disturbance like nausea, vomiting, and diarrhea, and miscellaneous like phototoxicity and the hyperkalemia, high level of potassiums in the blood. So this is all about the sulfonamide. If you still have any question, you may ask in the comment section. Thank you so much.